It's my pleasure to talk about a new study that we've just completed, looking at the effect of much smaller incentives than the amounts that we just heard about from South Africa on uptake of an important biomedical intervention for HIV prevention, which is medical male circumcision. Just as background, in the global development and also the HIV policy field, there's recognition that a number of proven health services, health products, and technologies have lower than desired adoption in many low-income countries. And there's an important literature in economics which has started to show that the prices of health products and health services are significant determinants of demand. But moreover, in many cases, even when services and products are available free of charge, as they are in the case of HIV services, the demand can still be lower than it's desired. And in that sense, the literature looking at the effects of relatively small incentives on demand for these services is quite important. I've summarized a few studies here that are relevant and perhaps of interest to those of us in this room. I want to say that despite the encouraging evidence on the effects of small economic incentives, there's significantly less evidence on alternative incentive-based interventions that further exploit insights from behavioral economics. I'm speaking here specifically about interventions such as lottery-based rewards as well as commitment contracts, and that's something that we are seeking to make an advance in this study. To tell you a little bit about medical male circumcision, the WHO has recently released a report showing that there's been remarkable progress in the scale-up of medical male circumcision in the last 5 years. Just in 2014, 3.2 million circumcisions were performed, and that's a dramatic increase from recent years. But nonetheless, the percentage of the target that has been achieved remains far from the 80% coverage level that many countries have sought, and male circumcision uptake has generally been lower among men who are above the age of 20 years, and that's an important age group for HIV prevention purposes. It's recognized that there's a need for demand creation interventions for medical male circumcision, and there's also a large literature on the barriers to male circumcision uptake for men who are 20 years and above. Financial concerns have been stated as one of the barriers, one of many barriers, and that gives rise to the economic interventions and the rationale for using them. I want to perhaps make a distinction between two different rationales for using these economic incentives, given that this is a session on behavioral economics. The very conventional standard economic rationale would be that incentives would offset the costs and the lost wages that men face, and therefore reduce the price of male circumcision. And then the behavioral economics rationale has more to do with the fact that incentives may offer an immediate reward and thereby increase demand among people who are delaying going for medical male circumcision. And it's worth recognizing that for male circumcision, a lot of the costs that men face are very much in the present, whereas a lot of the benefits from HIV prevention come in the future. The study I'm going to tell you about builds on a randomized controlled trial that we completed last year and presented at IAS in Melbourne and also published last year. That study focused very specifically on a standard economic incentive ranging from $2 all the way up to $15, and showed that these higher value economic incentives, which is specifically compensation to the men who came for circumcision, did significantly increase medical male circumcision uptake. However, the modest absolute effect size in that trial, as well as further consultations with stakeholders in Kenya and reliance on behavioral economic insights, led us to develop a lottery-based rewards intervention. So I'll tell you a little bit about the rationale for lottery-based rewards before launching into the details of the trial. The first comes from behavioral economics and prospect theory, which points out that individuals do have a tendency to place greater decision weights on low probability events, so that makes lotteries more attractive relative to a guaranteed amount of compensation. And there's also an expected utility theory rationale, which suggests that lottery rewards might be favored by individuals who who seek risk or who are less risk averse. There's been a number of studies done, mainly I would say in high-income countries, looking at the effects of lottery-based rewards. Very few studies done in developing countries. There's one study in Lesotho, which was mentioned earlier. But also there have been no trials that directly compare lottery-based rewards to a standard economic incentive. So the specific aim of the trial that was done in Kenya is to determine the effect of different types of economic interventions on male circumcision uptake over a 3-month period. We worked very closely with the largest provider of male circumcision services in Kenya, Impact Research and Development Organization, and we conducted then a randomized controlled trial in which there were 2 intervention groups. The first was an intervention that was very similar to the one studied in the previous trial. It was a fixed amount of compensation, a food voucher worth 1,000 shillings or US dollars, $12.50, that was provided to men conditional on uptake of medical male circumcision, and it was intended to compensate for the lost wages and transportation costs associated with male circumcision. The second intervention was lottery-based rewards, where individuals were given the opportunity to receive a variable amount of prizes conditional on uptake of medical male circumcision. Important to recognize that the expected value or the mathematical expectation of the 2 interventions was identical. The primary outcome was circumcision uptake within 3 months, and we focused on 21 to 39-year-old men who self-reported as being uncircumcised. The study was conducted in randomly selected sublocations in the Nyanza region of Western Kenya, specifically in the greater Nyando district. We conducted household visits and determined eligibility of individuals in those households and obtained informed consent. And following informed consent, individuals were randomized to 3 study groups, the lottery-based rewards, the fixed compensation, and a control group. And we monitored male circumcision uptake over a 3-month period and provided compensation to those who came for circumcision. There were 911 uncircumcised men enrolled in 2014, and the 3-month circumcision uptake period was completed in December of 2014. You'll notice in the enumeration list here that a large proportion of households were excluded from the sampling for reasons having to do with not having an eligible adult male, as well as having men who reported to being already circumcised. So in total, we enrolled 911 uncircumcised men. This table shows you the characteristics of the participants. The mean age was 29 years, and important to see the daily earnings here had a median of $3.8, and so the fixed incentive amount of $12 corresponds to roughly 3 days of wages. And the characteristics of participants were similar across all 3 groups. Also, in the baseline questionnaires that were administered to the men, the lost wages was in fact the most commonly reported barrier to medical male circumcision. This table presents the main results from the trial. The rows that are highlighted in the red table here show you that in the control group, we had 1.3% of men who sought male circumcision within the 3-month period. In the fixed compensation group, 8.4% of men became circumcised, and that number is very similar to what was reported in the previous trial. In the lottery-based rewards group, only 3.3% of men became circumcised. In logistic regression analysis, we find that the fixed compensation arm did have significantly higher medical male circumcision. The odds of circumcision uptake in 3 months were 6.8 times higher. In the lottery-based rewards group, the odds were 2.5 times higher and not statistically significant. We can also reject the hypothesis that the lottery-based rewards were as effective or equally effective as the fixed compensation study group. Some interesting findings from subgroup analyses. Generally, we find that the fixed compensation intervention did significantly better than the lottery-based rewards. However, there were some groups where the 2 interventions had similar effects. So those who reported having above median income levels responded in comparable ways to the lottery-based rewards and fixed compensation. as well as those who reported that cost was not their main concern. Also, relevant to the behavioral economics rationale for the intervention, when we asked individuals about their baseline intention of getting circumcised, those who reported that they were unlikely or definitely not interested in becoming circumcised were, in fact, none of them became circumcised as a result of the intervention. Where we did see effects were those who were among those who were contemplating medical male circumcision. So that's very consistent with the behavioral economics rationale that's typically offered for a small economic incentive, which is that it nudges individuals towards undertaking a behavior that they've been contemplating. So in conclusion, I'd like to highlight first that small amounts of compensation were effective in this trial as well as in the previous one that was done in the same region. And they were effective in promoting medical male circumcision over a very small period of time. And they were also most effective among men who reported having higher risk sexual behaviors. The absolute increase in male circumcision uptake, however, was fairly modest, but it's also large relative to what you normally see in this population, which is low levels of male circumcision uptake on an annual basis. So this is an intervention that we feel some countries should consider for populations that report having economic barriers. The other important result, of course, is that lottery-based rewards were not effective, and this is the first trial to our knowledge that actually directly compares lottery-based rewards to a standard economic incentive or compensation intervention. And I've listed a number of reasons that may explain this result. I think one important one is that men reported concern about not being guaranteed compensation for the cost that they really would incur if they became circumcised. And so that ambiguity about whether or not there would be a reward certainly played a role here. However, we can't definitively conclude whether a higher value lottery would have been more effective or not. We're currently doing analyses of in-depth interviews to learn more about the role that compensation as well as lottery-based rewards played in the decisions that men made, and we feel that the cost effectiveness of this intervention could be quite high given the HIV prevention benefits that have been reported as a result of medical male circumcision. I'd like to acknowledge a number of collaborators as well as participants and facility staff as well as funding agencies in this that made the study possible. Thank you.